elderly lady, severe knee pain, a cardiac patient. She came in and she says, I would like to be able to go and get my mail to my mailbox. I just want to walk there and come back and be pain-free. And I just can't do it, and I have to rely on my neighbors to bring in my mail. Well, she was a candidate for a genicular embolization. We did that, and she called us 2 days later, extremely happy, and she came in for follow-up in 10 days, gave me a big hug and said, "You've changed my life." I get my mail and I go out for a little walk every now and then.
Hey guys, it is Justin and I am here with the OBL Marketing Blueprint, and I am super excited to have my co-host Rachel with me today. But our guest today is Dr. Iqbal of Buffalo Vascular Care, and he is also the founder of the VIA convention? I'll make sure I say that right.
It's yes, VIA Symposium or VIA Symposium.
And for those who are not familiar with the VIA Symposium, tell us, Doctor, what is the VIA Symposium?
So VIA Symposium has been in the running for about 18 or 19 years, 19th year now. It's an attempt to reach out and educate the primary care providers about the new cutting-edge therapies which are out there.
Now, you've been doing this for quite a long time, correct?
Correct.
What year are we going into this year for VIA?
So this would be our 19th annual meeting.
Oh, wow. So you've almost 2 decades.
Almost.
So talk to me, how do you structure the actual symposium? Like if I were to attend tomorrow, what would I expect?
So the symposium is designed for providers, which means MDs, DOs, nurse practitioners, PAs. And the structure is purely educational and to provide updates. It's divided into 4 sections. The first section is dedicated to amputation prevention and wound care. The next one is to interventional radiology. The third one is to cardiology, and the fourth one is to neurointervention.
Interesting. And so how do you, I mean, as a marketing person, I'm always nerdy on this, but how do you market to these direct primary care or to these DOs? Like, how are you getting them interested in the event?
So as being in the community for a long period of time, we send out information via email. I make phone calls, and the structure of the meeting is that it's kept free to the those who come in, and the cost is borne by a nonprofit organization. And each year we try to raise money through industry donors, etc., to make this happen.
Awesome. So with this year, I was reading that the theme is the amputation prevention, innovative image-guided treatments. What brought that upon as the theme this year? Like, why is that something that's important?
Well, amputation prevention has been near and dear to my heart for many, many years. It started out because I'm a vascular interventional radiologist. I started out at the hospital, Buffalo General Hospital, back in '97. And most people at that time, including most primary care providers, did not really realize what an interventional radiologist is and what they do. And the hospital is like a black box. Patients go in there, get better, come out. And the role of interventional radiology was pretty much confined to the hospital. Just as a background, all image-guided procedures, including interventional cardiology, interventional neurointerventions, all started in IR. So the first angiograms were done by the interventional radiologist. The first cerebral angiograms interventions were done by IR. And as things progress, other specialties kind of took over these procedures and perfected them. So this is almost an incubator for the new technology, anything that can be done under image guidance from a remote access, hence minimally invasive. So going back to what we were talking about, there needed to be a way that the community primary care providers have direct access to interventional radiologists instead of going through a hospital system and having the patient being admitted to a hospital. And step one was educating people. So that's how the whole idea was born. And slowly it took momentum, and we built from, a handful of people coming around to hear us every year to now almost over 150 to 200 a year.
That's amazing.
Wow.
Have you had to battle at all? Like, just looking at the attendees that you have on this year's list, I mean, you have people from podiatry, vascular surgery, interventional radiology. All those people typically live in silos. Has that been a challenge to kind of integrate that?
Well, indeed, that has been our challenge, is to reduce the compartmentalization in medicine, and to help people feel comfortable enough to work together. And step one is to understand what each specialty does. And that has been the goal of the whole meeting. And that's why we started out by being pure IR to now amputation prevention, to IR, vascular, cardiology, interventional neuroradiology.
So kind of on that same note, why would you say that it's so important for amputation prevention to be collaborative? Like, why isn't it just one specialty that's in charge of that?
So that's a great idea. That's a great question, actually. And that started from my own passion to treat patients who have no surgical options. So our typical patients are diabetics who have arterial or blood vessel occlusion in small vessels below the knee. Now, these are usually not accessible to a surgical bypass. And even those who may be a candidate for a bypass have other issues going on, because the same arterial disease, which is in the leg, also affects maybe their arteries in their neck or their heart, and they would never clear for general anesthesia. And for those who will clear for general anesthesia for the bypass procedure, about more than half of them will not have a proper conduit, meaning the best outcome is using patient's own harvested vein. And about half of them would not have it. So at the end of the day, less than a quarter of these patients will ever get treatment. And while they wait for treatment, they lose their limb. And the data shows that patient with an amputation has 40 to 50% risk of dying in the first year.
Oof.
And about 60 to 80% risk of dying in third year, by year 3. And these rates are actually higher than most cancers. And this is not a known fact. So if you can save a person from amputation, you bring down their mortality rate. After amputation, the data shows that less than 50% of the patient who receive below knee amputation will ever get a prosthesis and be able to walk on their own. Less than 75% will ever have a prosthesis who receive an above the knee amputation. So these patients become bedbound, they go to the hospital, back and forth, they're depressed, and it's just a downward spiral. So if you can save somebody from getting an amputation and keep them mobile, it's good for their health and less people die. So that was the background. And since interventional radiology has been always a cutting edge specialty, unlike a surgical bypass, a lot of these small blood vessels can be treated by endovascular treatment, where you can actually cross these occlusions and restore flow. So I started out by doing that. And then I realized that endovascular is only a small component, because you can open up blood vessels, but you still need to have these patients go to the appropriate wound care and receive adjuvant therapies like hyperbaric oxygen, et cetera, et cetera. And we did not have enough of these in the community. So we started to speak to podiatrists, wound care centers, et cetera. And ultimately, I opened up our own wound care arm of practice with hyperbaric oxygen therapy about 3 years ago.
Awesome.
And we also have now podiatrists who work with us, and we work very closely with infectious disease people, the primary care, of course. So it's become a full spectrum. And that is the key of amputation prevention, is that you have to have all these services involved in parallel rather than in series to provide the timely care and to have the wounds healed in a timely manner.
Doctor, I don't know if you know Kim McNichols from Limb Saver, but we need to connect you two. You guys have a passion that is very similar on, I mean, she has a Limb Saver hotline that someone can call if they're in a hospital and they want to do an amputation, and her team will walk them through why they shouldn't and actually speak to the doctors and stuff. So I've definitely got to connect you if you don't know her.
I would love to meet her.
Yeah,
Absolutely.
you guys are saying, like, the way you throw out stats and stuff, she is so passionate about that. So for the primary care providers, like the OBGYNs, the podiatrists, what are some early warning signs that they need to pay attention to before that patient progresses to like actual limb-threatening disease?
So the easiest way to do for primary care, not necessarily OBGYN, but in primary care and in podiatry, is to take the patient, take like 2 minutes and have a screen of patients first. If a patient is diabetic and has had diabetes for like more than 10 years, ask them to remove their socks and just look at their toes. Because diabetes also produces neuropathy. So a lot of these patients don't feel any surface that they're walking on. They could be stepping on a nail and have the nail embedded in their shoe for days and not even realize that. So when people with diabetes have skin breakdown, blisters, that's the time to jump on it. And if the wound does not heal within a couple of days, send them to a special place, a wound care center with a multi-specialty staff who can look at this and take care of the wound and at the same time assess blood flow. And if there's a lack of blood flow, have the ability to send it to a proper expert who can take care of this using endovascular approach. Because endovascular approach also, one thing I neglected to say is that unlike bypass, which requires hospitalization, this is done in an outpatient setting and under appropriate conditions with the appropriate people doing it. It can be done in an office-based interventional suite, which we've been doing for like close to about 10 years now.
Now, you've been doing this conference for 20 years almost. Has it been surprising to you, even with the newer people coming out of residency, how few actually understand what an IR does or what the abilities you guys just mentioned?
Yes, it really is, because the first question I get asked by a lot of people is that you're a radiologist and you do what?
Yeah.
How many X-rays do you read? And then I have to explain that, interventional radiology is actually a boarded specialty on its own, and we are accredited and we are trained to treat peripheral arterial disease, venous disease, in addition to doing multiple other things. And since and that's why from day one, when we started this practice, we have a clinic. We actually see patients who are not in a hospital a silo where we get called to do a procedure. No, we are called with a problem. And we'll make sure that if the patient needs a procedure, whether I can do it or whether this patient needs a surgical solution, they get hooked up.
Can I ask a question real quick?
Sure.
Since this VIA Symposium is local, right, to your area, have you ever had local providers actually come visit you at your facility and see what you do? Because I know, once they come in the OR and they see the C-arm and the patient's awake and they can see all the visuals of what's actually happened, sometimes even watching a leg turn white to pink, right, can be like changing. Do you offer that for your local referring providers too?
Yes, indeed. I have an open invitation that anybody who has interest, please give me a call or a text, because I work best on a text. Just like come in and see what happens here.
I will just say to any provider on here watching, and not even non-provider, I did not go to medical school, but there is something miraculous about watching a limb be revitalized. Like the first time I saw that, it's just, I don't know, there's so few things in medicine that happen like that. And just, I don't know, it even tears me up a little bit. Just like you watch someone get life back in the area. So I would encourage you to go find an office that would let you watch that.
Mm-hmm.
Dr. Iqbal, talk to me. I looked at the agenda and I saw neurovascular care, and that's something new to me. I'm pretty in this industry, but I was not too familiar with that. Can you tell me, like, what are the treatments that kind of encompasses?
So In Buffalo, we've got a very strong and excellent neurovascular presence. We have Dr. Adnan Siddiqui and his partners who are world experts in stroke prevention and treatment. They use these advanced endovascular treatments to take care of a lot of these things. So that's why I invite people from that group to come in and to present to community what's out there. So a lot of these treatments are done as an outpatient, percutaneous, and they involve treatment of different vessels, which are obviously out of my area of specialty. So I really can't give you more in-depth information on that.
Well,
but I think it's done. I'm sorry.
No, you're fine. I was going to say my next question. I want to kind of keep it in your wheelhouse. With embolizations, it's traditionally been associated with oncology or fibroids, but you guys are really highlighting the expanding role. How are you seeing embolizations being used across different conditions in the current space?
Yeah, it's a very, very excellent question, actually. And embolization basically means that you are blocking blood flow. It could be done on the arterial side or the venous side. In general, it's done to starve an area of oxygen and blood flow. So, for example, instead of removing a uterus because it has fibroids, you can actually starve those fibroids of blood flow using small particles that go in there, they block blood flow, and those fibroids shrink. So you're preventing a major operation, hospitalization, 6 to 8 weeks of recovery, etc. In the same manner, you can starve the blood flow to a prostate, you can, etc. So the newest application is to the musculoskeletal system. Here, your target is actually the inflammatory tissue. So to give you an example, what causes knee pain in a patient who has arthritis? It is wear and tear, obviously, and the body's attempt to heal that area. But in the process, the attempt to heal that area causes a lot of inflammation, which in turn produces small nerve endings, which are the pain generators. People get the steroid injections to kind of calm that area down, and a lot of physical therapy, etc. But those things need to be repeated quite often. And the ultimate treatment is knee replacement. So for those patients who are not a candidate for knee replacement or do not want it for a variety of reasons, there's this new technique called TAME, T-A-M-E, transarterial musculoskeletal microembolization. And what this technique involves is that we put tiny catheters into the blood supply that goes to the knee. Typically, there are 6 different arteries with different branches going to different areas of knee. And then we use angiography, which shows us the blood supply and where the inflammation is. Once we identify the area of inflammation, which appears as a blush on the angiogram, we can size microscopic particles to go in there and to starve the area of inflammation of oxygen. With the new agents, the newest agent is actually an antibiotic. But when you dissolve it in a contrast, it breaks up into small small crystals between 50 and 150 microns, which is small enough to get to the really down to the level of inflammation. And it stays there for about 24 hours and then gets dissolved. So if these particles go in healthy tissue, they get dissolved in like less than an hour. So there's no really collateral damage. And what you're doing is you're starving off the inflammatory tissue. It becomes so-called ischemic and dies off. And with it, the new nerve endings. So you're actually treating the inflammation right where it starts. And the results are very durable out to about 2 years. And we combine this with actually physical therapy, etc., and exercise. And there's some excellent outcomes with that. And the same technique can be applied to things like frozen shoulders, elbow issues, chronic plantar fasciitis before they go for surgery. So it's a very new field, exciting. It started out in Tokyo, Japan by Dr. Kono, which, by the way, I'll be going to Tokyo actually next month to meet with him, and he's holding his first conference there. So you'll be very interested to see all the other work he's doing.
I've heard from others that have met him that he is a very soft-spoken, humble man for all that he's revolutionized.
He is. He's indeed very soft-spoken and humble.
You said something earlier as you were talking about the embolization that I think more in the business sense, since I'm not a provider. And I always think about, you're trying to create this network with OBGYNs and different people who could potentially refer. But it seems like one of the symposium's goals is to really reduce the amount of major interventions and surgeries. But that's often how some of these providers get paid. Have you struggled with that connection of like, hey, there's got to be a way to make this work for everybody?
Yes, I think that we are coming around. And to give you an example, uterine fibroid embolization. I brought it to Buffalo in 2001. And it was done, my first one was done in a hospital for a patient who was admitted with uncontrolled bleeding, had blood clotting issues, and the OBGYN did not want to operate on her. So we did embolization, got excellent results, and slowly it evolved. But there was an active, shall we say, suspicion or distrust between whether this really worked or not. And even the Society of OBGYN, it was not until recently that this was recommended as a first-line treatment. So most of our patients were self-referred. But by the same token, to the credit of medical profession, as we see things which are better for our patients, which are less morbid, at the end of the day, we go to med school to take care of patients, not necessarily to make money, because there are a lot of other easier ways of making money for the amount of work that you put in. So I think it just needs a little bit of more convincing and showing them good results, and people come around.
Well, I think having a symposium like this too, right, breaks down those barriers. Like, hey guys, this wasn't a one and done. You didn't trust me. We're going to keep trying to be friends. We're going to keep trying to educate and collaborate. I love the whole aspect of looking at the entire patient as a whole and not just, like you said, compartmentalize. I think you do your thing, I do my thing. But then one thing we hear is like the connection the patient doesn't understand or doesn't remember what Dr. A said before they go to Dr. B and Dr. C and Dr. D, to get down to that whole line. So I think this symposium sounds really awesome. I would love to be there next year. I know we just are kind of getting to know each other right now, but I think it would be really cool to see how this flow works and see how we can make it bigger. I think we need them everywhere.
Well, it is a lot of work and a lot of dedication, and the rate limiting point is really getting the right funding, because in these days, the industry, they are undergoing cuts. Everybody is under the knife. So it really takes a lot of understanding and building relationship with the industry to help fund this. And then I think the other barrier that is with the primary care is the money part, because it's expensive. It costs us about $350 per seat to put this program on. But I think what makes this exciting for the primary care is that, we have a lot of these meetings in our own discipline, but there's very little cross-pollination. So I think this serves and fills that niche.
Something you just had my brain going is, it's interesting with doing what we do for you guys, like the direct-to-patient marketing. A lot of doctors don't like the term marketing. That's just not their favorite term. But awareness, everyone's all for awareness. And I think, at least for Rachel and I can say, the amount of times that we've had one of our clients call us and say, hey, a patient saw the ad, went to their primary care, said, what is this thing? The primary care then Googled it because they had no idea. And so I want to encourage you for what you're doing. You are creating awareness when you market for these procedures, because it may not be top of mind for the ortho or for the podiatrist or for the, OBGYN, but by putting it in patients' hands, this day and age, information is available.
That is an excellent point. And also my goal is to create more awareness for my specialty too, because it's a very small specialty. It's usually behind many curtains in a radiology group, and people don't know what you do, even the primary cares. So I think that by understanding what we do, the patients have choices and the doctors have choices. And nowadays everybody's looking to cut cost of care. It's extremely expensive to get a surgical procedure in a hospital. Let's face it, typically it's anywhere between $40,000 and $70,000 to get a joint replacement, knee or hip, right? That's the usual numbers, but you can have for about $5,000 to $6,000 a procedure, which is the embolization procedure, which will carry the patient for like 2 years or more, and maybe that's all they'll need. So I think those are the examples of like where you can contain cost, and everyone, honestly, all the specialties are moving towards less invasive because it just makes sense. That's the way that we are also taught that in continuum of treatment, you start out by modification of behavior, diet, then you add some medication, and then do something minimally invasive before you actually go and open up somebody.
Well, and that's, Rachel and I were at an event last week, and it was like the doctor spoke who was speaking said, if I could just get every patient to walk 6,000 steps a day, like none of us would have jobs.
Right.
For the provider who's listening, who's maybe never attended the VIA Symposium, what would be your one sentence or two sentences? Why should they come?
Come in and get to know each other and see what everybody has to offer. And I think that knowing each other breaks down barriers. And my message again there is that try to get to know doctors who are treating your patient, the group of doctors. Try to get them to a point where you can talk to them via text. Because a lot of times the biggest barrier is lack of communication. You shouldn't have to go through hurdle. I shouldn't have to call a doctor that I'm sending my patient, call their office, put on hold, and then maybe have the office say, well, your doctor is busy, and leave us your number, and then never get a call back while the patient is in my office. So it should be right away.
You are literally the fourth provider I've interviewed this last 4 days that has said this same thing. It's communication is what's killing our patients. It's not being able to text. The patient has to come in and say, well, yeah, I think this happened to me, but they can't find out what the actual diagnosis was. And so the next doctor has to take it and figure it out. And it becomes a bad game of telephone, like, whoosh. And what do you think the solution is to that?
I think just doctor to doctor communication and breaking down those barriers. We have a lot of artificial barriers that we have created actually. And without going into specifics, I think that the way medicine is being practiced in large groups, hospital-owned, insurance-owned groups are less communicative than the private practice people are. And I think I'll leave it at that.
Yeah.
Now, doctor, if someone wants to find out more information about the VIA Symposium, what is the best way for them to do that?
Go on our website, and on the website top bar, there's a button for Symposium. Just click on that and you can register.
And for anyone,
or to call us.
And for anyone watching, we'll make a point to have that link in any of the posts or show notes we have for this so you guys can get it. Doctor, I love to ask this question at the end of every podcast interview is, what is your favorite patient story you've had in the last 3 to 4 months? Like, what is the person that just stands out? You're like, we changed this person's life.
Elderly lady, severe knee pain, a cardiac patient. She came in and she says, I would like to be able to go and get my mail to my mailbox. I just want to walk there and come back and be pain-free. And I just can't do it, and I have to rely on my neighbors to bring in my mail. Well, she was a candidate for a genicular embolization. We did that, and She called us 2 days later, extremely happy, and she came in for follow-up in 10 days, gave me a big hug and said, "You've changed my life." I get my mail and I go out for a little walk every now and then.
For
So-
anyone not doing embolization procedures right now, like the amount of times we hear that is it's every day. So I really encourage you guys to do like Dr. Iqbal, start taking these minimally invasive procedures, start changing lives. And if you don't know what that looks like, go to the VIA Symposium, learn all about it. And Dr. Iqbal, thank you so much for being on today.
My pleasure, Justin. Thank you very much.
Thank you.